All right, so this is Dr. Gallo presenting Chapter 9 on shock, sepsis, and mods.
Alrighty, good evening everybody, and thanks for listening to the annoying sound of my voice. We're going to do shock, sepsis, and mods, aka multiple organ dysfunction syndrome. I'll try and pepper in stories, and we'll have a break halfway through because it's probably going to be the better part of 2 hours. And here we go. So we'll be talking about shock, sepsis, and mods. Shocking, it's complex. It affects the body in multifaceted dimensions, which is absolutely true. And it's usually a mismatch between oxygen supply and oxygen demand. It's not so much, more often than not, we're talking about dysfunction at the cellular level. We're talking about oxygen utilization and oxygen delivery more so than a lack of oxygen supply. It's not, we're not talking about you are hypoxic strictly because you have pneumonia. We're talking about you have hypoxia at the cellular respiration level because your ability to deliver oxygen and nutrients to the tissues is compromised. And your oxygen demand is up because there's an infection and SIRS is engaged, which we'll talk about later. Basically, the process typically begins with localized tissue damage and ends in organ failure and death. There's a lot of hard science in this lecture. I apologize. Grab some caffeine. So cellular respiration produces ATP, adenosine triphosphate, and that's split up into 3 parts, which is actually not true because it's split up into 8 parts in the citric acid cycle and the electron transport chain, which is done 4 parts in glycolysis, which is 3, but whatever. Glycolysis involves aerobic and anaerobic metabolism. The citric acid cycle that follows it is strictly aerobic, so you need oxygen for that. The electron transport chain is strictly aerobic, you need oxygen for that. Glycolysis is the base system. It works no matter what, and this is it. And basically, this will work even if you're starved for oxygen, so you will still make some energy at baseline. Basically, all the C's are carbon, all the P's are phosphorus, and the 6-carbon chain up there is glucose. And basically what happens is you put 2 ATP in to get 2 ADP out, and that makes 2 I believe it's phosphoglyceraldehyde. And that then in turn you add 2 NADs and you get 2 NADHs out of it and 4 ATPs. And you make 2 pyruvate molecules. Pyruvate is short for pyruvic acid, and that's going to come into play later because pyruvic acid is going to be, acid production from an anaerobic environment, which is what you're often going to be doing glycolysis for in terms of the context of our patients is going to matter. And the net process of this is you get 2 ATPs. Ooh, I have a laser pointer too. Oh, neat. Anyway, you get 2 ATPs, 2 NADHs, and 2 pyruvate molecules out of it.
Poor friends listening at home will never see that though.
That's okay. So for those of you who can't see, I'm currently shining the laser pointer on the Purell box. It's fascinating. But I'm just going to try and break it up with interesting little tidbits because otherwise just some guy's just droning at you for 2 hours on basic science, and I used to do that for 4 hours a day, and that's what drove me insane. So basically the point of glycolysis is that this will work in an aerobic or an anaerobic environment, and you're going to make 2 ATP molecules out of it net, which is not a lot, as opposed to the Krebs cycle and the subsequent electron transport chain, which require oxygen and make closer to 20 to 30 per turn of the citric acid cycle. That is why cellular hypoxia is so dangerous, and that's what leads to organ dysfunction and death. It is not so much a lack of oxygen by virtue of a lack of ability to inspire oxygen because your lungs are screwed up, as it is a lack of oxygen delivery at the cellular level that happens during sepsis and multi-organ failure. That's what kills you. So for those of you watching on the slides, this is a transition reaction to the citric acid cycle. Basically, you take the pyruvate and you turn it into acetyl-CoA. You take acetyl-CoA and you put it in the citric acid cycle and you get more ATP out of it. You also make carbon dioxide, which is why you need to exhale, and you make FADH2 and NADH. I don't care. There was a time when I used to have to memorize this. Trust me, you'll never have to use this. You will never run into someone who has a citric acid cycle defect or a genetic inborn error of metabolism at this fundamental level because they all die. So in terms of aerobic metabolism, a lot of this is going on in the mitochondria within your cells, and they utilize glucose, amino acids, and fatty acids combined with the oxygen and the ADP we saw earlier to make ATP, carbon dioxide, everybody breathe out, water, and heat. Heat matters because it's what keeps you endothermic. It's what makes you endothermic in the first place. ATP is the actual energy that you need. That's the actual fuel that you're creating. And that's what you use to power everything. Anaerobic metabolism is sort of, I think of it like backup power. And what that allows is that allows you to do glycolysis, but not the citric acid cycle and not the electron transport chain, even without any oxygen on board at all. And it produces dramatically less ATP. It produces acid as a side effect and has a nasty habit of catabolizing all of your muscles as fuel, and that's bad. I'd much rather catabolize fat and sugar and water that I actually ate and drank. So where does all that go? If I make all that oxygen and all that energy and I deliver, rather, if I make all that ATP and I deliver all that oxygen, how do I actually get a hold of it? Basically, what happens here is the ACET boys refer to something as the microcirculation. What that is it's the arterioles and the venules. Most of you will know these as just plain capillaries. Arterioles are very, very tiny arteries right before capillaries, and venules are really, really tiny veins right after capillaries. And basically, the capillaries are what are woven in amongst all of your cells, and they are what really, that is the location where the oxygen diffuses out of the blood vessels and into your cells, and the carbon dioxide goes out of your cells and into your blood vessels. This is really where the oxygen carbon dioxide exchange actually happens, and they're everywhere, especially in your lungs where you do the oxygen exchange, and especially at the cellular level, the actual tissue. For those of you who have the original slide packet, there's a typo here. The phrase is homeostasis, not homeostasis. Homeostasis is basically the normal biological, everything's functioning good state of the cell, where you have enough oxygen to meet your demands. Those demands are going to go up during sepsis, and that might lead to tissue ischemia just by virtue of it outcompetes itself. Or your ability to deliver oxygen at the cellular level may go down, secondary to poor perfusion most commonly, but also microclotting, and we'll talk about that in terms of sepsis and how exactly you are your own worst enemy later. The cardiovascular system delivers oxygen-rich blood to the tissues. If anyone doesn't know that at this level at this point, come see me. When the oxygen-bound hemoglobin gets to your capillaries, it releases oxygen and it exchanges that for carbon dioxide. It says cellular waste, it's mostly carbon dioxide. Curiously, for those of you who like medical trivia, carbon monoxide from your average cigarette binds to hemoglobin with 100% greater affinity than carbon dioxide and oxygen do, which was always amazing to me. How do you not just light up a cigarette and instantly die or asphyxiate? Isn't that weird? Anyway, it's just one of those things. This is a good picture of the microcirculation. Basically, oxygen comes in your lungs, gets down to the capillary level, gets into the capillaries, into the capillary bloodstream, specifically gets into the iron molecule iron atom within the hemoglobin molecule within the red blood cell. That's what it's really doing. And then the red blood cells go to point B, i.e. your heart, your liver, your arms, your brain, whatever it may be, gets to the capillary level there, goes out of the capillaries, goes into your cells. The cells give back the CO2, goes into the capillaries, which then gets carried back to your lungs, and out it goes, most of the time. Incidentally, the whole electron transport chain system and the subsequent development of carbon dioxide and use of oxygen is the entire reason you have to breathe. The only reason you actually breathe is to support this particular cellular reaction. So, everybody with me so far?
Yes.
Okay, cool. I promise that's the end of the hard biochem. We're about to do an ode to Howard Kuchai. For those of you who never met him, Howard Kuchai teaches physiology at UVA. The guy's an excellent teacher. He's brilliant, but he's also kind of a sadist. And we used to joke he had a PhD for the invention of pain. You want to talk about some hardcore physiology, drill a spoon through your head kind of classes. That was him, and he would love what we're about to do. So 4 stages of shock. The initial stage of shock, the compensatory stage of shock, the progressive or decompensated state of shock. That's another minor typo that's in your packet. It's decompensated, not decompensatory, because no one talks like that. And then refractory or irreversible state of shock, which is when you're in serious yogurt. So the initial stage, blood flow to the microcirculatory beds decreases. What does that mean? That means that by virtue of the systemic inflammatory response, the increased demand and usually decreased supply, or maybe just straight up hypoxia from pneumonia and you have bacteria, or CHF and you have fluid occupying a good chunk of your lungs, your ability to deliver oxygen to the capillaries drops and hypoxia develops. And they mean hypoxia at the cellular level here. They're talking about cellular hypoxia in terms of the cells can't get enough oxygen to run the system. It's not so much there's a PE and it's causing hypoxia, or there's lack of oxygen absorption because you got a pneumonectomy. They're talking about cellular level metabolic hypoxia, and cells cannot maintain homeostasis. Then you got the compensatory stage, which is where your body does what it can to make the situation better. Increased heart rate, increased vasoconstriction, maintain that cardiac output, which is heart rate times stroke volume, increased respiratory rate, which is maintain your minute ventilation, which is respiratory rate times tidal volume, and increase sympathetic response. And we'll talk all about what that does. And that will work for a time. And usually if you're running 911 or if you're doing early interfacility transfer, you'll see a lot of patients in this compensatory stage here. I just realized that my laser pointer doesn't show up on the LCD screen. Oh well.
Not well.
That's okay. Otherwise, I'd just be pointing at things all day. So the issue here is that this will work for a while, not indefinitely. And eventually you will, as the toilet indicates, go down the tubes. For those of you who can't pick it up on the microphone, there was just a toilet got flushed. That will work for a while. Here's what's going on during that compensatory phase where your body's doing its best to stabilize things while the doctors, nurses, and you in the back of the specialty care or critical care ambulance try to resuscitate someone from sepsis. You have decreased cardiac output. Cardiac output is heart rate times stroke volume. So that leads to decreased blood pressure. That causes your body to basically pull the oh shit handle, and that is sympathetic nervous system activation. Sympathetic nervous system is your fight or flight. That's norepinephrine, epinephrine, catecholamines, and unfortunately your own worst enemy, inflammatory cytokines. Tumor necrosis factor alpha, interleukins, that kind of stuff. We'll get to that. But basically your blood vessels, in that case, you constrict the integumentary system. You constrict the skin. That's why they're cool and pale and diaphoretic. You vasoconstrict the things you don't need, your kidneys. I can't imagine not needing my kidneys for very long, but it will happen. That's why your urine output drops off, and you get to the nursing home and they say they haven't peed in 3 days. Well, this is why. It vasoconstricts the GI tract, which is why you get intestinal ischemia, and that's why you get dead gut, and dead gut kills you. It dilates the skeletal muscles so you can move around. Everybody run away from the tiger. It dilates the coronary arteries, so you maximize perfusion of what you need, your brain and your heart. It dilates, it causes diaphoresis at the sweat glands, so if you go to an ICU and you see somebody who's in sepsis that you're thinking, do I intubate this guy, do I not? If they're diaphoretic, do it, because you're likely suffering from cellular hypoxia. You need to improve that oxygenation. Increases your heart rate, increases the rate and depth of respiration in your lungs, and dilates your pupils. The rate and depth of respiration in your lungs is to maximize oxygen, oxygen delivery, and CO2 exchange. Also, that CO2 exchange, the blowing off all your CO2 and leading yourself to a lower PaCO2, basically causes cerebral vasoconstriction, which will in turn cause a small degree of cerebral ischemia, which is why you feel lightheaded when you have a panic attack.
What causes the dilation of the pupils?
The sympathetic system. It activates the sympathetic nerves, which will dilate your pupils because your third cranial nerve runs along there. And if the parasympathetic system is active, it'll constrict you. And if the sympathetic system is active, it'll dilate you. It has nothing to do with the actual vessels. It's just a nerve that runs into cranial nerve 3, if I'm not mistaken. In terms of your kidneys, we're still in the compensatory stage of shock, so everybody move to the next slide if you're watching at home. It will cause decreased renal blood flow. In terms of that, remember, because you decrease the perfusion to the kidneys don't like that very much, and so they produce renin, which basically says, pay attention to me, I like blood too, and they're sort of selfish. They'll try and perfuse themselves as best they can. The renin production will lead to aldosterone, which leads you to reabsorb water, pee out potassium, and reabsorb sodium in the process, because where solute goes, water follows. And basically what that allows is it allows you to retain fluid. What your kidneys are trying to do here is retain fluid to selfishly perfuse themselves. And this is part of why you see people with sepsis who look like the Michelin Man, because they start third spacing. They put fluid everywhere but their blood vessels. It shows up in their tissues. It shows up in between the spaces between their cells. They look all blown up and huge. And it's also because we give them liters and liters and liters of crystalloid. And we'll get to that too. Your hypothalamus is going to activate, remember, it goes hypothalamus, pituitary, adrenal glands in terms of the HPA, or the hypothalamic pituitary adrenal axis. And that is sort of how your endocrine system works. Now, this is slower. It doesn't work as fast as your epinephrine, and it doesn't work as fast as your increased heart rate. It doesn't work as fast as your increased respiratory rate or anything like that, but it will happen. The posterior pituitary is going to release antidiuretic hormone, which is kind of a double negative. Antidiuretic hormone is don't have dilute urine. So basically what that does is diuretic would be peeing out lots of fluid. Antidiuretic is going to stop you from peeing out lots of fluid, therefore you retain water. That's what it's really trying to get you to do, is save the fluids, because it thinks you're dying of hemorrhagic shock or hypovolemic shock or whatever else. Anterior pituitary is going to release adrenocorticotropic hormone, which for those of you playing at home is ACTH. That causes the release of cortisol. That causes hyperglycemia and also tries to jack up your blood pressure. Incidentally, if you ever have patients with adrenal insufficiency, that lack of cortisol is how you get to hypotension, because the cortisol also drives blood pressure. That's why those guys need steroids, and that's why steroid-dependent people, when they get septic, need steroids on top of their steroids.
And so that's why we see that new protocol.
Yes, that's why that's in the state protocols. Also because you got a couple kids running around with adrenal insufficiency, and if you don't give the steroids to them when they're sick, they tend to get worse. They're steroid dependent. And then it gets down to your adrenal medulla, which releases epinephrine and norepinephrine. It's really the principal parts of your sympathetic response. There is such a thing as Addison's disease, primary adrenal failure, which is actually pretty bad. You can actually have those go south. In terms of still having compensatory stuff, how else can you get screwed up? Cardiac output goes down, so you're not perfusing the vital organs as well. You get decreased blood flow to the lungs, and this is where you start getting the cellular level hypoxia stuff, because it gets increased physiologic dead space. What the hell does that mean? Basically, it is the lungs need blood too, and so when you have decreased blood flow to the lungs, you can have perfectly working lungs with no edema or no pneumonia in them, and you can be sending oxygen into those lungs. But if there's not enough blood supply running past to pick up that oxygen and deliver CO2, that lung isn't really doing anything. That's why a PE is so nasty. That's called dead space. Yeah, that lung just isn't functional. Even though there's nothing wrong with the lung, it's the blood flow to the lung that sucks. And so there's no one to carry new oxygen to the body or deliver the old CO2 out. That also stimulates the chemoreceptors, which are a series of, as the name would imply, chemical receptors that will alert your body to, oh shit, and those are actually located in the, if I'm not mistaken, carotid sinus. I could be wrong. Maybe the carotid body. I'd have to look it up. But anyway, actually it's the carotid body, if I'm not mistaken. Increased rate and depth of respirations happens as a result of that. You're trying, because you know that there's increased carbon dioxide, because you're not clearing it, so you try and breathe off all the carbon dioxide, and that's why you end up with a respiratory alkalosis. You see the ABGs on these ICU patients, and they always have a low PaCO2 initially, because they're blowing off all the carbon dioxide. So that gives you a respiratory alkalosis. That is compensating for your increasingly worsening metabolic acidosis that your chemoreceptors detect. And the respiratory system works a lot faster than the metabolic system, so you will blow off CO2 much faster than you will retain chloride or retain bicarbonate in your kidneys, which will take you 72 hours. You see somebody start breathing quickly, that's usually an earlier sign of sepsis. You also get people who are chronic COPD patients, chronic CO2 retainers, heavy cigarette smokers, etc. They'll always have a metabolic alkalosis to compensate for their chronic respiratory acidosis. Anyway, so, and this is what we talked about before, at the bottom of the green box, the respiratory alkalosis that you do from breathing really quickly will basically cause cerebral vasoconstriction, which causes cerebral ischemia, which causes the lightheadedness, the decreased level of consciousness. That's both the lightheadedness from panic attack and the grandma's been acting funny since she got the urinary tract infection. How many of y'all have ever gone to the ICU for delirium? Altered mental status plus infection. The hallmark of delirium is there's an infection of some sort and it causes a waxing and waning alteration in mental status. More common than not, hypoactive delirium, which is they're not as interactive as normal and they're just kind of laying there like a bump on a log. The more one that gets more attention, the hypoactive delirium gets left in the nursing home for 2 or 3 days because Mrs. Jones has been very quiet today. She's just fine. Wrong.
So it's not the infection that's causing the altered mental status, it's the cerebral ischemia that's causing it.
It is your response to the infection, which includes cerebral ischemia, that's causing it. I mean, it could be meningitis, and that'll screw with you, but more often than not, it's other stuff.
Secondary, not primary.
Right. 70% of all infection in people over 65 is pulmonary and urinary. Additionally, you're going to get, after that, if you let that go on, you're going to get a progressive or decompensated stage of shock. That's when your blood pressure starts to drop off a cliff. Don't let anybody say, oh, he's not septic because he's not hypotensive yet. Key phrase in there is yet. This is septic shock. This is when you decompensate, it becomes a true life-threatening emergency. The underlying disease is left untreated or just more often than not, just unrecognized for long enough. And that's when you start really having to get heavy on the fluids and the vasopressors, and you start breaking out the levo and the vasopressin and the epinephrine and all that stuff. That's when you need central lines and that kind of stuff. Then you get the refractory irreversible stage where you get the compensatory mechanisms that totally fail and you just can't keep up enough with both the lack of cellular oxygen delivery, the lack of waste and CO2 excretion, the lack of cellular metabolism. Too many tissues are dying from lack of enough oxygen to run the Krebs cycle and the citric acid cycle, and the tissues and organs start to die, and that's when you get an exponentially higher mortality rate. That's why the mortality at a lactate of 4 jumps up exponentially to something like 50% during sepsis as opposed to a lactate of 2, which is why there's that big emphasis on clearing the lactic acid as early as you can. Anyhow.
Is clearing the lactic acid beneficial, or is it clearing the cause of the development of lactic acid? Which one is more important to you in the ER?
It is clearing the infection.
Okay, so we're fixing the source first.
Right, but you really want both. Clearing the infection will stop the problem at its source, but it's not so much the lactic acid that is damaging, it is the presence of the lactic acid that indicates the production of a substantial amount of anaerobic metabolism. It means that you have this cellular hypoxia, that you have the metabolic derangement. That's why you have the lactate in the first place. It's not that the lactate's going to get you.
So we're not just flushing lactate with fluid too.
Right.
For the fun of it.
Well, you are flushing the lactate out. I mean, don't get me wrong. You're using the fluids to increase the tissue perfusion, to maintain enough blood pressure to allow tissue perfusion, to maintain cardiac output. But it's not the lactate that's damaging it. It's the cellular hypoxia that is causing the lactate production. That is what's really going on. And the infection is driving that. And also, as we'll see later, the response of your body is also driving that. All right, so to change gears for a minute, I've changed this slide as well. This is the effects of shock on the body in terms of function. When we talk about multi-organ dysfunction, eventually everyone in this room, including me, will die. And we will likely die of multi-organ dysfunction syndrome. That's what death is. It's multi-organ dysfunction syndrome. Things shut down. How do they shut down? How does shock actually hurt you? In terms of your heart, you start getting cardiac arrhythmias and cardiac failure. Lack of oxygen delivery to the heart basically gives you globalized heart attack, and you get myocardial hypokinesis. So you don't pump very well. Cardiac output being heart rate times stroke volume. Stroke volume sucks. Heart rate can go up and maintain cardiac output for a time, but not indefinitely. In the lungs, you get pulmonary hypertension, pulmonary edema, and ARDS. ARDS really is pulmonary edema. It's not pulmonary edema from congestive heart failure. It's pulmonary edema because part of the inflammatory response is capillary permeability at the capillary level, and fluid just kind of extrudes out everywhere, and that's why they look like the Michelin Man. Some of that fluid goes in their lungs. That's ARDS. You get brain ischemia or infarction, basically altered mental status from this. Not enough blood flow to the kidneys, like we talked about. Your body considers the kidneys non-essential, which shunts fluid away. So you get decreased urinary output, subsequent oliguria, tissue ischemia in the form of ATN, acute tubular necrosis, and ultimately kidney failure. And so you look at the labs on these patients that you're going ICU to ICU or ER to ICU with, and their creatinine will be much higher than normal most of the time. Here's the fun part. You get stress ulcers and ischemic bowel. If it's real bad, that's a later sign. Unless, of course, the ischemia or infection is a direct shot to the gut. Dead gut kills you faster than a lot of other things because that's a combination of feces, bacteria, and necrotic tissue. That's really bad. Mesenteric ischemia is very dangerous. That's usually marked by pain out of proportion to exam, a high lactate, and usually a propensity for hypovolemia or poor circulation. People with AFib, people with known aneurysms, known vascular disease. It's like a heart attack in your guts. Not how I want to go. Your pancreas can also get ischemic, which then releases all the fun proteolytic enzymes and destroys everything in its path. And who decided this was a good idea? Intelligent design, my ass. Myocardial depression factor. Your pancreas can do this. So there's a function where your pancreas gets ischemic and starts depressing your heart. What a great idea. Let's do more of that. Yes, please. Your liver, hypoglycemia and toxicity. What does that mean? Well, your liver is in charge of filtering a lot of the toxins, a lot of the uremic, blood urea nitrogen out of your body. It's filtering all of your drugs. So if you get an older person who's on Ativan, just by virtue of the liver being not as functional when you're 95 as it is when you're 35, it will not break down those drugs as well, and so they last a lot longer. They give Mrs. Jones Ativan for her agitation, and they're confused when she's still tired 12 hours later. And then you're septic and your liver doesn't work as well, and they're confused when she's still tired 3 days later, and then they decide to call us. The hematologic and immune system, you initially get a leukocytosis followed by a leukopenia, classically. Now, old people, immunosuppressed people, the very young, well, the very young typically mount a good white blood cell count, but the very old typically do not. And you don't necessarily need a white blood cell count when you don't necessarily get a white blood cell count when you're septic. You can be septic and not have a high white blood cell count. You can be septic and immunosuppressed by the medicine you're taking to avoid rejecting your kidney and not have a high white blood cell count. You can be leukocytotic and then leukopenic and say, oh, his white blood cell count is 2. It's not very high at all. I guess he's fine. Wrong. SIRS, systemic inflammatory response, which we will beat to death in about half an hour. And DIC, which is disseminated intravascular coagulation. That is a very late problem. That is basically your body chews through all of its coagulation factors in an attempt to do something, anything, to stop the spread of the infection, and also by virtue of your inflammatory response turning everything on, and your PT and PTT go through the ceiling, your INR goes up, your fibrinogen goes down. You basically burn through all your clotting factors, and you go through this crazy cycle of clot, bleed, clot, bleed, clot, bleed at the microcirculatory capillary level. And you start clotting off at the capillary level all of your organs, your liver, your kidneys. You start getting localized ischemia, like millions of little DVTs. And that starts killing you by 1,000 paper cuts. Adrenal insufficiency, we talked about that, hypotension and hypoglycemia. All right. So in terms of multi-organ dysfunction syndrome, there are 2 types. One of them results from a direct insult, which is trauma. I guarantee you, if you get shot with a shotgun in the liver, your liver will not work as well. Everybody understands that. Everybody doesn't understand that, again, come see me. Secondary, more progressive insult to the organs, this is really what we're talking about. This is something else has gone wrong downstream that is going to mess with your organ function. Much more common. This is really what we're talking about in terms of what MODS really is. This is how sepsis kills you. This is how we're all, unfortunately, one day going to die. And it's going to get your most metabolically active organs first, a lot like chemotherapy. Your brain, your heart, your kidneys, your liver, and eventually your adrenal glands as well. This slide was clearly made by someone who hates fun. So everybody take a drink and then we'll explain it.
I think their drinks at home are better than yours.
Okay, so we're going to play a drinking game. Every time we see one of these giant, super busy charts, everybody takes a shot. But they're there for a reason, and they are accurate. I will try to distill it down into what you will actually see in terms of patient care, because otherwise it just becomes 1,000 things you have to memorize. So basically, this is a version, if you page back to the one that says effects of shock on the body in terms of function, this is effects of shock on the body of hyperperfusion in terms of physiologic changes that you get to the various organ systems. I made that change again in the PowerPoint. I know that's not what it says, but that's what this is. So we are on table 9.4, the vertical one. Neurologic system, you get altered level of consciousness. Grandma seems confused today. Grandma's less interactive. That's what that looks like. It's not, oh, you know, she's having a stroke today. No, that's usually not how it works. It's usually global cerebral ischemia and dysfunction. Pulmonary, tachypnea, hypoxemia, PaO2, blah, 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 blah. What does that mean? It basically means you breathe real fast, you get hypoxic, and if you look at an ABG of these people, they have a low PaO2, low partial pressure of oxygen, less than 70 typically, a low SaO2, except COPD patients where I'll take anything over 92, and a PaO2 to FiO2 ratio less than 300. What the hell is that? All right, so when you look at your ventilators and when you look at your ABGs, the ABG is on the PaO2 is on the ABG, and the FiO2 is the fraction of inspired oxygen that you are allowing through the vent. Usually when you start off, it's at 100%, and you kind of titrate it back down to get your SaO2 happy. When that ratio of PaO2 to FiO2 is less than 300, so think about it right now. I bet my PaO2 is probably 100, I hope, except for that giant PE I'm about to get right now. Okay. And the FiO2 at room air at sea level is 21%. It's actually mostly carbon, oxygen, nitrogen, helium, krypton, argon, and some other stuff. But it's only 21% oxygen. So if you divide 100 PaO2 over 0.21, your PaO2 to FiO2 ratio sitting in this room ought to be about 500, roughly. If that's under 300, that's ALI, or acute lung injury. That's early respiratory badness. If that's under 200, that's what defines ARDS. And these are usually typically people on high concentrations of oxygen with very bad hypoxemia as a result of pulmonary edema that's either from CHF or ARDS as a result of the systemic inflammatory response, which we will describe shortly. Everybody still with me?
Yep.
Okay. Cardiovascular standpoint, high heart rate, hypotensive. So you'll see a guy in early compensatory shock, heart rate of like 110, blood pressure is what we call soft, 90 over 60, 100 over 70, gets lightheaded when they stand up, that kind of stuff. Systemic vascular resistance goes down. Basically, you vasodilate, which is bad because then you're not vasoconstricted enough to perfuse your vital organs. That's why they have these bounding pulses and they feel really hot, at least at first, and then they turn cold and blue. Cardiac output goes down. CVP is central venous pressure. Normally that's 0, but in this case you want it to be 8 to 12. That's going to drop because they vasodilate and everything goes down. Arteriovenous shunting. Basically, that's what we talked about earlier with the physiologic dead space. You get a lot of blood flow where it doesn't need to be, and you get no blood flow where there should be oxygen. So your lungs are trying to breathe oxygen because you're breathing really fast. Give me some cellular oxygen. I know at a cellular level that I'm starving, but I can't deliver any of it to my body because my blood flow in my lungs sucks. And this is arteriovenous shunting, or an AV shunt.
Is that from the precapillary and postcapillary sphincters
Your arteries have a much greater propensity to vasoconstrict than your vessels. If you've ever done an ultrasound on somebody, much thicker walls, they have much more control. Your veins, you will venodilate, but they don't have as much smooth muscle around them to allow that. But in general, you'll have, if you check somebody's radial arterial pulse, when somebody's early sepsis, they'll have, they'll be pale and they'll be hypotensive, but they'll have these crazy good pulses for a while. And then they'll vasoconstrict and their skin will get very cold, very pale, and they'll be very mottled. And the longer that goes on, the worse it gets. Renal, you get system shutdown, so you don't get as much urine. The difference between oliguria and anuria is less urine. I think it's less than 40 milliliters a day versus anuria, which is not technically 0, but less than 100. It's very tiny. And the creatinine goes up and up and up because you're not peeing it out. Liver function. Most people who get septic do not get jaundiced. I know the thing says you get jaundiced. You don't really get jaundiced. You just have elevated liver numbers. Now, this is just because this drives me insane. Have you ever been to a trauma alert or a trauma code where somebody says their vitals are stable? They mean good, right? You can be a rock and be stable. You can be dead and be stable. Dead people are perfectly stable. Dead people will never change. But stable in this case means unchanged. When they say their vitals are stable, what they usually means is their vitals are good or reassuring. They are within acceptable limits. If that's what you mean, say that, because vitals are stable implies a lack of change here. In similar terms, liver function doesn't mean transaminases and alkaline phosphatase. That's what it means by elevated enzyme levels. The AST, ALT, alk-phos are your elevated enzyme levels. That's when you get hepatitis or liver ischemia from lack of good oxygenation, lack of good blood flow, liver shock liver, they call it. That's when the AST, ALT go up. Liver function, the things the liver actually builds and makes and does, that's the PT, PTT, INR stuff. That's when that's elevated. That's what liver function really is. Decreased albumin levels, just decreased protein, general malnutrition. Hematologic, decreased platelet count and decreased platelet function. Your PT, PTT are up. Your protein C level is down. Your D-dimer level is up. This is why D-dimers on really sick patients to rule out a PE is useless, because they're going to be elevated. Pregnant women also have elevated D-dimers. And your adrenal glands, again, hypotension, hypoglycemia. All right. Have I driven you all crazy yet?
Wild.
Good. Mildly crazy. Good. So let me see. I'm trying to figure out interesting story time because I feel like I should break up the monotony here. Crazy time. All right. We talked about crazy people. My personal favorite schizophrenic delusion of all time I ran into. I had a guy who swore he had microchips implanted in his eyes by the government that he could use to blow up airplanes with his mind. And so I don't know how exactly that worked, if he had, some kind of Iron Man thing going on, but basically the story went that the way he showed up in my psychiatric hospital when I was in Stanton, Virginia at West State, or whatever it's called now, was that he was at National Airport staring out the windows at various planes, staring real hard for hours on end, trying to explode the aircraft with his mind. And by this point, he's, I don't know if this is true or not, but this is the story of how he got there. And he was his insight was very poor. It was very bad schizophrenia. And eventually some policeman walked up to him and said, "What are you doing?" And by this point, he's crazy. And he just turns around, he's got the wild bug eyes, and he goes, "I just blew up one of your planes with my eyes. What do you think about that?" And at that point, he came to me. So crazy is always relative. Next time you see somebody who's a little anxious. All right, speaking of anxious, we're going to do classification of shock. And what exactly does that mean? We're going to talk about cardiogenic shock, hypovolemic shock, and an umbrella term, which is distributive shock. Among distributive shock, there's neurogenic shock, there's anaphylactic shock, and there's septic shock. We're going to spend most of our time with septic shock, but you could get some neurogenic shock or some hypovolemic shock in your travels as SCT, CCT type people. So in terms of cardiogenic shock, this is the heart pump mechanism is failing. Whether it's global ischemia from lack of good blood flow and infection and subsequent SIRS and inflammatory cytokines, which actually causes myocardial suppression, whether it's a heart attack and subsequent left ventricular failure, whether it is a pericardial tamponade or a pneumothorax or a pulmonary embolism that basically gives you external compression or so much afterload you can't overcome it, or whether it gives you just myocardial failure from progressive cardiomyopathy, guys with amyloidosis or alcoholic cardiomyopathy or postpartum cardiomyopathy, whatever reason, heart failure is cardiogenic shock. Everybody take a shot. I'm waiting. Okay. We're not going to dwell on this too much, but keep in mind where the way to understand this chart in terms of findings of cardiogenic shock is where does the blood that fills that chamber come from. So the left ventricular blood comes from the lungs, the pulmonary veins, and the right ventricular failure comes from the body, your arms, your legs, and your head. Biventricular failure, that's truly uncomfortable. If that were me, just give me brownies until I die. So left ventricular failure, your heart rate's going to, and right ventricular failure and biventricular failure, and God knows you guys are going to see CHF patients all the time. Heart rate's going to be increased no matter what. Blood pressure for individual failure is going to be within normal limits initially, and then as you decompensate, it's going to drop because your cardiac output goes to hell. When both of them are failing, you're just going to crater. Pulse pressure, that's the difference between systolic and diastolic pressure. That's we narrow in all of them because the heart doesn't relax very well, doesn't fill during diastole, and it doesn't pump out very much during systole. So the pressure doesn't really change all that much. And you'll see these guys with these really narrow blood pressures and bad CHF. 120 over 100, 110 over 90. And the kind of numbers where you kind of think the cuff is wrong, but that lower number can't possibly be that low or can't possibly be that high. And as a result, it looks really, really narrow and the pulse pressure is like 20 or 30. 120 over 80, your normal blood pressure, that's a pulse pressure of 40. That's nice and wide. Pulmonary capillary wedge pressure, or PCWP, I don't care. You're not going to see anybody with a Swan-Ganz catheter except on a very rare occasion. I do not expect you to interpret it. But basically, that's going to be increased in left ventricular failure. Cardiac output, that's heart rate times stroke volume. That's going to suck in all failure. Systemic vascular resistance, any one individual pump fails or both of them fail, your body's going to try to vasoconstrict and try to increase the pressure so that you can perfuse those vital organs, which you can do for a while. And that's why you get vasoconstriction in the skin, but your heart still has enough blood flow to run that system. Your SVO2, the systemic venous oxygen supply, that is going to be decreased in all cases. There's not a whole lot of oxygen going in the arteries, or sure as hell ain't a lot coming out of the veins. Urinary output, no matter what happens, your kidney blood flow isn't all that good, and so your urine goes down. In left ventricular failure, the blood backs up into the lungs, so you get pulmonary edema, not JVD. In the right ventricular failure, it backs up from whence it came into the arms, the legs, and your neck, and so they're going to get JVD. CHF patients, if it's right ventricular failure, you get JVD. CHF patients, if it's left ventricular failure, you're going to get pulmonary edema and dyspnea. If it's biventricular failure, you're going to get both. Peripheral and, or you're going to get JVD no matter what. And in the same vein, bad pun. Oh, God, bad pun.
Second turn.
God. On the third strike, I have to do a dance. But y'all can't see it because I'm on audio only. Anyway, don't you wish we were here for the live session? Then again, I heard if you're a football fan, banned white men dancing on the field is at least a 10-yard penalty. So in terms of edema, if it's left ventricular failure, it's going to back up into the lungs, you're going to get pulmonary edema. If it's right ventricular failure, it's going to back up into the legs and the arms and the neck, you're going to get JVD and leg edema. Most commonly in CHF and right ventricular failure, it's going to go to the legs first, and you get those big doughy legs with the pitting. In terms of heart sounds, left ventricular failure, you're going to get S3. That's right after your S2 second heart sound. So instead of pom pom, pom pom, pom pom, pom pom, you're going to get pom pom pom, pom pom pom. It's like an extra one after S2. Pom pom pom. It's subtle, but it's there. Before we had echocardiograms, people relied on that almost exclusively, and that's a breed of diagnostic capability that is, by and large, less prevalent now. And I admit I'm not as good at it as I should be.
Is that a delay in one of the valves closing?
It's an extra sound. It's actually left ventricular stiffness can also do that.
Okay.
You get this boom, 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 right after S2. Like you almost can't tell it's a separate sound. Right ventricular failure, you don't really hear much. Biventricular failure, you can get an S3 or an S4. S4 is right before S1. So you've looped back around and now you're doing boom, 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 boom. All right. Then there's hypovolemic shock, which is comparatively easier. That is, you have bled to death, pooped yourself to death, or dehydrated to death for whatever reason. I love this. This reminds me of the military style way of discussing things. Fluid lost or displaced internally or externally. How does that sound? Somewhat similar to bleeding to death from the inside. So if you have a bad trauma, you have fluid displaced internally because you're bleeding from your liver or your kidney or whatever. It's kind of like if you vomit. You don't vomit. You have an involuntary personal protein spill. Anyway, other associated conditions, fever, vomiting, diarrhea, burns too. Burns are actually a way to get hypovolemic shock. Your skin is actually a primary barrier against fluid loss and heat loss and infection. And if you get a bad burn, you just weep plasma. I'll take an 80-year-old over a pneumonia with a 40-year-old with a bad burn any day. Give you an example. I had a guy when I was in Virginia where meth is a little bit more common in the Virginia and Appalachia area. I had a meth lab in his house. Wasn't meth, I forgot. This guy went to sleep with a cigarette next to him and lit his sheets on fire and cooked himself. And he had about an 80% second degree total body surface area burn. And you always had to handle this guy with gloves because you would touch him and all this sticky plasma would come off on your hands.
Oh, nice.
He'd just weep onto the bed sheets, and we'd have to change bed sheets every couple hours because it was like, imagine the cold sweat from hell. And this guy lost fluid like nobody's business. He'd lose liters a day. And that's actually hypovolemic shock. So you get tachycardic, hypotensive, and confused. All right, shot.
Another one.
Yeah, I know. I'm going to make this one simpler, though. This is basically the only one that matters here is the second row, which is percentage blood loss. If anybody's going to talk to you in terms of critical care or trauma care, in terms of blood loss, this is classification typically of hemorrhagic shock. This is defined by the ACS-COT, which is the American College of Surgeons Committee on Trauma. They're responsible, they're sort of the JACO version of the boogeyman for trauma centers, i.e. Stanford Hospital. And class 1, class 2, class 3, class 4 hemorrhagic shock is defined as what percentage of your blood volume you lost. Class 1 is less than 15%, class 2 is 15 to 30, class 3 is 30 to 40, and class 4 is greater than 40. I think of it as 4 greater than 40. You start getting serious physiologic derangement in the class 3, class 4 territory. And I don't expect you guys to memorize all of these individual changes, but what you do want to see is the changeover that happens from 2 to 3, when you start to go off the cliff. Central nervous system, you start to get anxious and confused. You get a guy with bad blood loss or bad fluid loss who's getting altered, you need to get control of that airway and start heavy-duty fluid resuscitating that man. Starts getting cool or cold, pale, and moist. He starts getting diaphoretic, that's bad. Diaphoretic is always a sign of bad sympathomimetic stuff. You get guys with, are you not sure this guy's having a heart attack or not? He's diaphoretic, that's almost a guarantee. Urinary output goes down. Class 3 is also different from class 2 in that you start breaking out the blood. And you guys may be called to transfuse blood on either a GI bleed or a bad trauma or whatever that's going from point A to point B. That's all I really care about, so we're moving on. Distributive shock. Distributive shock is an umbrella term. Neurogenic shock, anaphylactic shock, and septic shock. Neurogenic shock, you got to be careful because you'll hear people say spinal shock. It's really kind of a bad term. Spinal shock is really the spinal stunner, where you get hit in the back and you get numbness and tingling in your legs temporarily, and it goes away after a couple hours. I had a guy one time do that during a lacrosse game, and I was providing medical coverage on the field for it, and everybody was flipping out. We, back when we used backboards, and we had him all tied up and stuff. He goes to the hospital 3 hours later, the bruise is gone, and the neurological status normalizes, and he goes home. That's spinal shock, really. Neurogenic shock is somebody transects your spinal cord with a piece of shrapnel or a piece of a car or gunshot or a knife, and everything's inferior to that. Everything's or a fractured vertebrae from a fall, a car accident, that kind of stuff. everything inferior to that cuts off your sympathetic tone. Parasympathetic tone wins by default, and everything goes to hell in terms of what the sympathetic nervous system does. Vasodilation, bradycardia, hypotension. Normally you have tachycardia with your hypotension, but in this case it's bradycardia because you don't have any fight or flight below that level, not to mention the paralysis part. Anaphylactic shock, that's your vasodilation, swelling, itching, hives, sometimes abdominal pain, vomiting. The difference between true anaphylaxis and anaphylactoid is anaphylaxis requires IgE, immunoglobulin type E, for mediation. Anaphylactoid just directly degranulates all your mast cells, and it's the same difference. It's a difference, but it's the same functional thing. I doubt anyone's going to walk up to you and go, "Oh, you should know this is anaphylactoid, not anaphylactic." It's kind of the difference between oxygen doesn't technically explode, it supports combustion, still leaves a big old fireball. So anyway, and then you get septic shock, which is what we're going to spend most of our time with. Oh, God. All right, shot. Hang on. Little do y'all know, is this water or is this Everclear?
It's something, all right.
I don't know who came up with all these charts, but Jesus. Anyhow, basically, in terms of what this talks about, what this chart really talks about is the differences in hemodynamics between hypovolemic shock, be it from dehydration or traumatic blood loss, and two types of distributive shock: neurogenic shock from a spinal cord injury or anaphylactic shock. The heart rate with hypovolemic shock is going to be increased because you're trying to save yourself. Anaphylactic, same thing. Neurogenic, your sympathetic goes to hell, so you can't increase your heart rate even if you want to. Hypovolemic shock, you're going to be normal, but eventually you're going to dump your blood pressure late. Don't wait for that to happen. That's a late sign, especially in children. Anaphylactic shock, you're just going to vasodilate because that's what anaphylactic shock does. Same thing in neurogenic shock. Pulse pressure is going to be narrow in hypovolemic, narrow in anaphylactoid, and normal in neurogenic. They're going to be bizarrely unperturbed. They're going to be hypotensive as hell, but they're going to have a normal heart rate, and pulse pressure is going to be normal. That's because they can't compensate for the vasodilation even if they wanted to. They can't raise their heart rate because the sympathetic nervous system that was in that spinal cord you just cut in half with the shrapnel or the bad car accident or the vertebrae that cut it is gone. Pulmonary capillary wedge pressure, again, I don't care, but it's decreased in all of them. And the only real difference here is that your systemic vascular resistance in hypovolemic shock, you're going to at least try to save yourself. You're going to vasoconstrict. But everything else, anaphylactic shock, which vasodilates by virtue of how the immune system response works, and neurogenic shock, again, you don't have the sympathetic tone, you can't help but vasodilate. That's also going to decrease your systemic vascular resistance.
Dr. Gill, will professors work in neurogenic shock?
You mean if you get neurogenic shock and then an infection?
No, as far as helping them sustain
nope,
vasodilation.
can't do it. Can't really do it.
I had a patient like that. It fell off a ladder, and he could feel nothing from the neck down.
Mm-hmm.
Bilateral lines, low blood pressure, low heart rate, alert and talking to us. He died in casting.
Yeah, you want to, at some level, your body wants to do that. Because what's your natural state? You're hypotensive as hell. You want to have a compensatory tachycardia. You should be. If you have hypovolemic shock, you certainly will be, as you can see in the upper right-hand corner. But because it depends on where that denervation happens, you lack the ability to do a tachycardia. You lack the ability to vasoconstrict. And
but
so,
if you gave them a constricting drug, if you gave them back when this happened, it was dopamine, would that constrict them?
It might work for a while. I mean, I don't know if you put them on dopamine drip indefinitely.
So if we were to instill
We did, but he died.
Yeah.
So we want levofed, we could get direct connection to the localized cells to cause vasoconstriction.
It still might be really tough to do.
Okay, so it's a last ditch effort.
Yeah, naturally you're not going to do that because the nerve signal for that to happen is never going to get there.
Right.
If you send in, vasoconstrictors at a cellular level, maybe.
So we get a little local action, but not.
You're not going to. It's not going to be a long-term solution.
We dumped thousands of.
Yeah, it ain't going to work. You can try. I mean, there's a great study that came out a couple of months ago, 2015, that showed that use of pre-hospital epinephrine increases the rates of pre-hospital ROSC, but it decreases 30-day mortality. It increases 30-day mortality and it decreases overall 1-year survival. it's proof positive with enough pressures you can get water from a rock. You can vasoconstrict eventually, but not indefinitely. And you got to wonder what else you're vasoconstricting while doing so. There's a lot more cerebral ischemia, there's a lot more coronary artery ischemia, etc. My dad helped work on the F4 Phantom jet engine, and it had the aerodynamics of a brick. But he used to say it was proof positive with enough power a barn door could fly, but not forever. That's better. Anyway, speaking of which, time to take a shot. Another one of these. We're getting into SIRS, and just for giggles, why don't we take a 5-minute break? Because this is the second half of this lecture, and y'all are tired, probably sick and tired of listening to me gab.
So we'll mute the camera or mute the microphone for 5 minutes and be right back.
Sure. Thanks, Joel. Why don't we get out here at night? By 7:30, it's not on. Night shift is on all of a sudden. I don't know if the ACEME or ACM or CEME Corporation,
this week.
College of Accreditation in Medical Education, would agree.
Yeah.
All right, we back up?
We are back up with everybody in the room, and your tie is off, so we're looking good.
All right.
Just call our boss and tell him we'll be tired tomorrow and to not give us 50 things to do.
Okay. So we are back. We're going to talk more about SIRS and sepsis, which is a big chunk of who you'll see. And then we'll talk a little bit about blood administration and nuts and bolts of that, since we can do that now. So first of all, shot. We got another table. SIRS. This is systemic inflammatory response syndrome. This is basically what criteria do you have to be worried about when you come up to your patient in the ICU or in the ER or whatever. What vital signs should scare you? So temperature greater than 38 Celsius or less than 36. Hot or cold. You can actually get hypothermic, especially old people. They get hypothermic when they're sick. Respiratory rate greater than 20, or you're breathing so fast that you're blowing off your CO2.
I don't think so.
Sorry. Or you're breathing so fast that you're blowing off your CO2 and your PaCO2 is less than 32 millimeters mercury. Heart rate greater than 90. Keep in mind, old people don't mount a tachycardia, and people on beta blockers don't mount a tachycardia. White blood cell count greater than 12 or less than 4. Remember, early on, you get leukocytosis followed by leukopenia. Or greater than 10% bands. Basically, this is the body going all hands on deck, even the rookies. And they're sending out the immature band-type neutrophils. It's called a left shift. Definitions of sepsis. There's sepsis, there's severe sepsis, there's septic shock, and then there's Monday night with Angry Carol. And the fourth one is definitely deadly, especially if you're not pulling your weight. But the first three are also bad, so let's talk about that. For those of you who don't know, I love Carol. She's awesome. She's the night shift charge nurse at the ER. Just don't get in her way, because you need shit to get done. She's going to get that shit done, even if it requires her stepping on your neck to get it done. But anyhow, sepsis, severe sepsis, and septic shock. Sepsis is when you get 2 or more SIRS criteria plus an infection, often bacterial. Severe sepsis is sepsis plus at least 1 organ malfunctioning. So you're starting to get kidney failure, you're starting to get pneumonia with hypoxia, you're starting to get altered mental status. And septic shock is hemodynamic instability plus SIRS. That's basically sepsis plus hypotension. All right, another shot. Basically what this is the various definitions of sepsis and what it does to you. And a lot of this is the SIRS criteria, so don't be too scared of this chart. But basically it's a temperature greater than 38, not 38.3, wrong. It's greater than 38 or less than 36, heart rate over 90, respiratory rate greater than 20, or you're breathing so fast you blow off all your CO2, and it's a PaCO2 of less than 32 millimeters mercury. You start getting third spacing, you start getting edema, especially if you're getting greater than 20 milliliters per kilogram of fluid in the first 24 hours. And altered mental status, confused, delirious, change from baseline. So how many of y'all have ever been to this call? You wind up in the ER and the patient had a fever, a UTI, and altered mental status. And the responses are both wildly inappropriate or they're hypoactive. So you touch them or you touch their IV line and the response is, whoa! Or you touch them and they have no response. They're very torpid and they don't interact with you appropriately and that kind of stuff. That's often what you get. Hypoactive delirium is actually much more common than hyperactive delirium. In terms of inflammatory response, we talked about this already. White cell count greater than 12, less than 4, greater than 10% bands. Sometimes you don't see plasma CRP levels very much. You do see them on some cases where you suspect there's an inflammatory reaction, but you're not sure. That has to be greater than 2 standard deviations above normal. Or you get a procalcitonin level, which is increasingly common among internal medicine guys. You'll see hospitalists admitting people out of the ER getting this, and you'll see ICUs getting this. A procalcitonin level is basically an inflammatory marker of sepsis. And if that's greater than 2 standard deviations above normal, then you start worrying about sepsis. It is not a SIRS criteria. Keep in mind the first chart is the official SIRS criteria. That's only temperature, respiratory rate, pulse, and white blood cell count. This is just other stuff that you can look at in the vitals and in the labs and see and suspect sepsis in the first place. Hypotension. Again, don't wait for this. Hypotension is not a SIRS criterion. Hypotension is septic shock. That's late. If you're waiting until they're hypotensive to realize that they're septic, you done fucked up. Especially children. They don't drop their blood pressure until later. So kids can look good. Kids can compensate very well. They spend a long time in that compensatory phase, and then they drop their pressure late. So that's why you got to resuscitate them early and aggressively. Again, systolic blood pressure less than 90. This is actually not internally consistent. A map of less than 65 millimeters mercury should worry you. Systolic blood pressure decrease of greater than 40 millimeters mercury in adults are greater than 2 standard deviations below the normal adult range. No one uses that. Ignore it. SVO2, this should be less than 70%, I think. But that's, again, not going to be something you're going to see unless you have an arterial blood gas or venous blood gas from a central line. Cardiac index, again, you're not going to see that unless you have an echo or Swan-Ganz, and nobody does Swan-Ganz anymore. Basically, what those numbers mean is greater than 3.5 liters of blood flow per minute per square meter of your body's surface area. Good luck calculating that in the back of an ambulance. Bullshit. So we don't use that very often. That's why it's not a SIRS criterion. You'll start seeing end organ dysfunction. Again, we talked about the acute lung injury where the PaO2 to FiO2 ratio is less than 300, or ARDS, which is just a worse version of ALI, at less than 200. You're going to start getting, remember, you don't perfuse your kidneys very well, so you get decreased urinary output, increased creatinine. You're going to get less than 0.5 milliliters per kilogram per hour for at least 2 hours. Creatinine is going to go up. INR is going to go up. Remember, the INR is a ratio. It's just a number. PT, PTT, prothrombin time, and partial thromboplasmin time are actual markers of the extrinsic and intrinsic coagulation cascades respectively, and they are measured in seconds. So when you see INR of 1.2, it's just 1.2. When you see PT of 34, that's 34 seconds. How long it takes to coagulate that section of the clotting cascade. And yes, we are going to get to the clotting cascade. Get out your power drills, prepare to shove them through your head. Ileus, absent bowel sounds, not the same thing as bowel obstruction. Just remember that your gut runs on a separate nervous system from the rest of you. It's called your enteric nervous system. Anybody ever eat a sandwich and have to consciously think to themselves, I am going to digest this sandwich now?
I tried.
If you have, come see me. Because I have a room for you in the ER. It's called the Blue Zone. It's where we keep all of our psych patients. But normally you don't have to, because you got your enteric nervous system. It runs on its own. You've got digests on its own. You swallow pretty much on your own. I mean, you can voluntarily swallow if you want to. But when you are infected with something, be it every GI bug you've ever heard of, or sepsis from something else like your gallbladder or UTI, oftentimes she's been constipated and has no appetite. Grandma hasn't been eating for 2 days. Grandma might have an ileus. It's where your entire nervous system shuts down and you get basically gut stoppage. You get thrombocytopenic, get an elevated bilirubin, though that's rare. Hyperlactatemia, cute name, lactic acid go up. We talked about that before. Delayed capillary refill, skin gets mottled, especially visible in children. So sepsis, I don't know whether this is, we're getting better at catching it. And if that's true, good for us. Or there's just more of it, but the CDC thinks there'll be as many as 1.1 million new cases by 2020. It can hit all population age groups, especially the very young and the very old. If you're in an ICU that doesn't do heart patients and is primarily like a medical ICU, some places divvy them up like that, some places don't. It's the number one cause of death. It's overall 10th leading cause of death in the country. Number one, 15 to 45 is car accidents, unless you go to certain places in North Carolina, at least when I was there in 2012, when it was actually opioids. Imagine that.
Yeah.
Opioid overdose, more deadly than trauma for young men.
That's crazy.
Hey guys, I'm going to take this heroin is now more dangerous than, hey guys, watch this. Holy shit. Anyway, among older people, everybody north of 45, and I don't really count that as old. I count old as anybody 20 years older than me. Exactly. Or anybody north of 85. Nobody in this room, right? Right? We're safe? Good. Among that age group, the most common cause is heart disease. Sepsis is only number 10, but it's very nasty and very tough to treat. Sneak up on you in a couple of days, whereas heart disease usually takes 30 or 40 years. Oh God, I forgot this.
Shot.
Yep, hang on.
Chris just joined us late, so we're taking a shot every time there's a horrible table.
We're up to 12 now for those of you playing at home. Okay, this is a chart that I actually think is really good because this is the people you need to be afraid of. And this is a lot of the SCT people that you will do. Who is going to get septic? And a lot of this is very intuitive because you've seen this by sheer law of large numbers. But just in case you need a reminder, the very young and the very old, people who are immunosuppressed in general, the very young and the very old, cancer patients, immunosuppressed both from the cancer and from all the chemo they're on, transplant patients, immunosuppressed by design with anti-rejection medicines, HIV patients, the disease kills your immune system, immunosuppressed patients. Okay, just in case nobody got the vibe yet, but anybody with immunosuppression, diabetes, pregnancy, alcoholics, multi-comorbid chronically ill old people, they just don't fight infection as well. You don't get a white count. You don't get a fever. You don't necessarily get a tachycardia. I wish I could show this chart to every internal medicine physician I've ever had an argument with. Well, she's not tachycardic. She can't be sick. No, she absolutely can be sick. And they don't necessarily present with one. And that's why it's on us from an SCT, ED, ICU standpoint to have a high index of suspicion for these people because they can fool you and deceive you when everything appears normal on the surface until you start getting into the history of altered mental status, decreased urinary output, that kind of stuff. Chronic and coexisting diseases, people who are chronically ill with other stuff. Diabetes, again, they don't heal well, their microcirculation sucks, they don't get blood supply to the organs that need it very well. They're also immunosuppressed. Everybody ever see a diabetic foot ulcer that lasted for 10 years? When's the last time you had a paper cut that lasted for 10 years? Yeah. Those people in the room who don't have flaming diabetes with a hemoglobin A1C at 15. Nobody, right? The difference in how a diabetic heals from a fracture, from sepsis, from a wound, from a surgery, from trauma, night and day. COPD, same thing. Liver cirrhosis, absolutely. Heart failure, kidney failure. Who's going to recover faster? A 30-year-old man who gets a mild pneumonia and takes an azithromycin for a week? Or an end-stage renal disease patient with COPD, diabetes, and heart disease who gets a pneumonia?
Probably never, yeah.
Never. They'll never be the same. On average, for every day in the hospital, 3 or 4 days of rehab. What's the mortality rate from a hip fracture over the first year after the hip fracture? Is 50%. Not from the hip fracture, but from the DVT and the pneumonia and the dehydration and the urinary tract infection from the Foley catheter they had and the blood clot and the sacroiliac ulcer and the altered mental status, and then the family wouldn't take them back, so they were in the nursing home, and they got transferred, and XYZ happened, and then they wind up in the ICU, and the SCT team gets called to take them to Yale because you're a nowhereville and they can't handle that.
Same
Anybody
thing with
heard
hip
that?
replacements for the elderly.
THRs, Ptolemies, shoulders, spinal surgery. Who hasn't heard of that? And if you haven't, you will.
We have a 96-year-old aunt who had a hip replacement and did amazing.
That's great.
She's
Very
the other
unusual.
Yeah.
She is the
I
exception
argued
to the
with
rule.
my cousin, who is a physician, why would you have your mom do that?
A lot of
at
times,
this age?
orthopedics, the older you get, depending on your quality of life and your functional status pre-op,
Right.
won't touch them. But that plays into what is their functional status preoperatively. If they're alert and sharp and active and doing their thing, then yeah, they're more likely to intervene. But if they're chronically bedbound in a dementia ward in a nursing home, you're probably not going to touch them. Not worth it. Other infections that can just make you septic, meningitis, absolutely. Cecily Neisseria meningitis, for those of you who don't believe in vaccines, come see me. I have a bridge to sell you in Brooklyn. Community-acquired pneumonia, cellulitis, urinary tract infections, absolutely. Increasingly, antimicrobial resistance. For those of you who don't understand that evolution exists, come see me. Next time you get MRSA, I will treat you with ampicillin and we'll all laugh. Critically ill patients, or rather methicillin, even better. Let's just use methicillin on MRSA.
We get the irony.
85% of all ear infections are viral. The most common antibiotic prescription in America is antibiotics for pediatric ear infections. If it's not pus drum, they don't need it. American Academy of Pediatrics recommends against it. What we tend to do is we'll give it to them for 48 hours, and we tell them to wait for 48 hours. You give them the prescription, but you tell them don't take it. And if they get better in 48 hours, throw it away. You don't need it.
So they fill it immediately.
I don't know if they do or not. A lot of times they don't, which is great. That lies on us, though, as ER docs, to do good patient education and work closely with their pediatricians. But organisms with antimicrobial resistance is actually an increasingly big thing. There was a great time-lapse video that they did at Harvard that showed bacteria in real time developing resistance to bugs. And it would select out all the ones that didn't have resistance, and then the other ones would kind of stop and overgrow it and take over. And eventually the bacteria would be able to handle higher and higher concentrations of antibiotics, and you could actually watch them march across the screen, run into an area with a higher concentration of antibiotics, and pause for an hour or a day, and then eventually take that area over too, and then hit the higher concentration and pause for an hour or a day, and then take that over too. And this wasn't a different strain of bacteria. It was just developing the ability to handle higher and higher capability. That's how fast they mutate and evolve. Human beings selected ourselves out of natural selection a long time ago, but trust me, it's still around and Mother Nature does not care. Invasive catheters, prosthetics, heart valves, central lines, urinary catheters, ports, abdominal surgeries, all those guys can get septic. In terms of pathogens, it's usually bacteria. Your body identifies it as non-self and pulls the immune system fire alarm. Inflammatory process kicks in, everybody take a shot. This is basically what it does. It will vasodilate you, which gives you the bounding hot pulses. So you look red and heat and produce a lot of heat, even though you're actually hypoperfusing yourself. You turn a pipe that's normal size with a good deal of water in it into a gigantic pipe you could walk through with the same amount of water in it. And that's relative hypotension for those organs that blood was going to and that oxygen was going to. That's why that vasodilation is so dangerous, because your blood pressure locally just went to hell because you vasodilated everything. You get smooth muscle contraction, so you get bronchoconstriction, and these guys get increasingly dyspneic. Increased capillary permeability, which is why you see so many of these sepsis patients looking like the Michelin Man, because they get capillary permeability at the cellular level, and they get third spacing. They get very plethoric, very swollen. They also get capillary permeability in the lungs, which is how you get non-cardiogenic pulmonary edema. They just fill up with their own fluids. Burn patients will do that. Stimulation of pain receptors, that one's pretty obvious. The thing that is infected usually hurts. That's a cue that it's over here, but it's not always the thing that hurts that is bothersome to you. It activates a systemic inflammatory response, hence the term SIRS, systemic inflammatory response syndrome. Eventually, your inflammatory response can be so excessive that it actually hurts you. The pro-inflammatory, pro-coagulation cascade, decreased fibrinolysis, i.e. fibrin, the substance of clots, you don't break that down, so you make more clots. All those inflammatory cytokines, all that inflammation actually puts you in a state of harming yourself. You shunt blood and oxygen away from organs that need it. You create thousands of little microclots in this pro-coagulation cascade, and everything is on fire and not functioning very well, and you're your own worst enemy after a while, which is why you got to get the sepsis under control. This is, if you want a really granular level of how this works, TNF is tumor necrosis factor, interleukins and various inflammatory cytokines get kicked on in SIRS. That's what gives you the fever. That's what gives you some of the edema. That's what gives you the tissue hyperperfusion and vasodilation and all that vasodilation, hence tissue type. Yeah. Let's try this again. They give you the vasodilation, hence tissue hyperperfusion, hence localized ischemia, hence end organ damage. That's what's really driving it. Neutrophils, which are primarily antibacterial white blood cells, are activated. That's what that greater than 10% bands thing means. There. Greater than 10% immature forms. So that's where actually all that comes from. Immune response is disrupted, and now you got SIRS. Okay. This isn't take a shot, this is drill a hole in your skull. There was a time when I used to know this by heart, and I realized that if I need it, I can look it up. But the easiest way to remember this is, in terms of your clotting cascade, and after this, I promise there will be story time to reward you for not killing yourself during this slide. There's an extrinsic and an intrinsic pathway to your tissue coagulation factor. Extrinsic pathway is what warfarin and Coumadin act on. The way I remember it is WEPT, so-and-so WEPT. W-E-P-T, warfarin, extrinsic, PT. Extrinsic malfunction gives you an elevated PT, and is what warfarin acts on. That's why your INR is high when warfarin's up. Intrinsic is PTT, partial thromboplastin time, which is really APTT, activated partial thromboplastin time. And everything on this slide that has an A next to it is activated or active, going to do something to some other molecule, version of that factor. So like you see factor 13 and factor 13A, that's activated factor 13. It actually goes and does things. So your extrinsic pathway, which is activated by tissue damage, turns on tissue factor alpha or tumor necrosis factor alpha, depends on which TNF you're talking about, which in turn does a bunch of other crap and eventually turns on factor 10 into factor 10A. Your intrinsic pathway, which is caused by blood vessel damage, which could be from the infection, could be from trauma, could be from surgery. Also activates a bunch of other stuff, factor 12 to 12A, 11 to 11A, more calcium involved, blah, 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 turns on factor 10A. Rather, turns on factor 10 into factor 10A. Factor 10A gets calcium, factor 5, platelet phospholipid, and turns prothrombin into thrombin. You don't really care about thrombin, except that thrombin turns fibrinogen into fibrin, and fibrin is what makes clots. And you also turn 13 into 13A, and 13A turns fibrin that's loose into a tight fibrin clot. Why does anyone care? Why does this matter? Because two things. One, this is what you normally do when you get a cut on your arm and it stops bleeding. And on average, this takes 6 to 8 minutes. It is also what you do when your sepsis and SIRS, when you have sepsis and your SIRS response gets out of control and you hyperactivate this clotting cascade and cause a bunch of microclots at a very, very small, granular, cellular level. and you start causing 1,000 small DVTs to your kidneys and your muscles and your liver and your brain, and you get tissue ischemia. You don't deliver blood and oxygen and nutrients to those guys. This is what's really driving a good chunk of that. You actually make a bunch of clots. And in DIC, this gets turned on even higher. You burn through all your coagulation factors and you clot everything. And then you bleed all over the place because you have nothing left at all. And then you make some more, you clot everything, you bleed all over the place because there's nothing left at all. And you can imagine how bad that is for end organ damage. This I just stuck in this slideshow. It wasn't really there. This is the time course of severe sepsis. You'll see the shock will last for the first day or two, the oliguria the first 3 days or so, the brain dysfunction over a week. It takes a long time to recover from this. ARDS, that's the PF ratio of less than 200, up to 12 days. Acute lung injury, up to 9 days, that's the PDEF ratio less than 300. All right, so story time. Somebody mentioned to me transporting patients at the wrong time of day. A couple years ago, I was with Pegasus Air at UVA, and we were flying to a hospital that shall remain nameless to pick up a patient who had something wrong with him, and I'll keep it at that. And we discovered that this patient was really sick. He was on 4 different drips, and it took us a while to get him into the helicopter and get all of his drips onto our pumps and get everything set up. It took, it takes a long time to set up all that stuff. Make sure it's all compatible with your equipment, you run flight. And meanwhile, I'm looking at my little Doppler radar app on my phone, and I realize there's a giant freaking thunderstorm coming at us from the west. And it's going to be there in about 35 minutes. So we're in the ICU when I look at that, and we're like, we got to go now. And so we go out to the helipad, we put him in the helicopter, we take off, and we're taking off, and I'm literally looking out the window with this giant thunderhead that's coming in. Like, shit, are we going to make it to UVA on time? I don't know. The place is about an hour away, and we're flying an Augusta 109, which is a lot faster helicopter than most. It's about 140 knots. And we lose Doppler, not navigation, but we lose Doppler tracking for some reason. It just goes out. That's the other problem with Augusta, is the maintenance costs are through the freaking ceiling because everything breaks. But we lose Doppler tracking in the helicopter, and we don't know where the storm is. All we can do is look out the window and go, it looks like it's over there-ish. And so I pull out my cell phone, and I've got it next to the pilot. So I'm sitting on the left, pilot's on the right. And I'm like, okay, literally the free Doppler app is determining where the helicopter goes. Do we divert to this other hospital? How many minutes do we have? And it's doing a little time-lapse radar thing, and I'm watching it creep across the screen like a game of Space Paranoids. And we get there, we land, we go into the ICU, the helicopter takes back off again and flies up to the airport. And about 5 minutes later, skies open up on us. And yes, we flew a $4 million helicopter with my iPhone. Anyway.
No, it's Samsung.
You might as well have been the pilot.
No, you don't want me to fly a helicopter, but it was interesting to do that.
Yeah, I bet it was
fun.
Very interesting.
Fun. I mean,
you were having a good time?
Oh, yeah, absolutely.
You're daring.
It's fun. Anyway, so in terms of sepsis assessment, you go to the ER, you're going to take out of the ICU, you go to one ICU, you're going to go to another ICU. Got to have a high index of suspicion. Oftentimes you'll be called because they're septic or they have some other problem and you suspect there's some underlying sepsis. This is where your index of suspicion has to be pretty high. You got to be pretty suspicious. Trust no one, especially old people. Nobody hides illness and injury like drunk people, and nobody just craters for no apparent reason or for multiple reasons simultaneously like the elderly. Kids fool you and look very, very normal until the last minute. Everybody else is fair game. You need a thorough patient history and a good physical exam when you start. The infection is not necessarily required. They may have had some or other insult that put them into your hands, and then there's the sepsis later, a day or two later. Fever may not present in all populations. Got that? For anyone who didn't hear it the first 3 times, old people don't get fevers. Immunosuppressed people don't get fevers. And then you might have distributive shock, which again is the neurogenic shock, anaphylactic shock, septic shock. You could have cardiovascular shock from heart attack or MI or PE or cardiac tamponade or whatever. Or you could have hypovolemic shock, hemorrhagic shock, which is comparatively, when you look at all the other physiologic changes that happen in the sepsis part, the easy one. And we have plenty of fluid. We have enough blood most of the time. We can do that. So the earlier you catch it, the better. And you want to optimize your fluid resuscitation to optimize that cardiac output. Because remember, cardiac output is heart rate times stroke volume. And if you can get that volume back and increase that cardiac output, increase the blood supply, increase the pressure at the pressure head at the capillaries, it's shoving oxygen in and taking CO2 out, that's the best. Remember, there's nothing oxygen exchanging about saline. It's water with sodium chloride in it. It does not have a heme molecule in it. There is no iron in there. It does not carry oxygen for shit. It just increases your cardiac output. So that's where you eventually need infection control and eventually blood, and we'll get to that. Because changing their whole blood volume out like a Chevrolet at a Jiffy Lube does not help you perfuse any better. Vasotropic and inotropic support, this is a little bit of an older slide set, so I added levofed in there, dobutamine, phenylephrine, actual epinephrine, vasopressin, those are just pure vasoconstrictors, and then ultimately you want infection control. So this is another shot. This is a chart about, this is more of an ICU level thing. We don't monitor central venous pressure off a central line in the back of an ambulance. But if you see it in the ICU where they tell you that his CVP was 5, so we added levofed and now it's 10, so you're okay, this is what this means. A lot of times you need a central venous line and arterial catheter. They may be sedated, paralyzed, or intubated. Oftentimes if they're intubated, it's just sedation afterwards. We don't chronically keep people paralyzed. You start getting neuromuscular weakness of critical illness, which is actually a thing. Normally, your central venous pressure is 0. In this case, sorry, let's wait a minute until the backup alarm's over. I apologize. I guess you can edit this later, right?
I hope so. If not, everybody here knows what it is.
Beep, beep, beep.
We lease the building, so we're very careful backing in.
There you go. Good idea. Anyway, all right, so that's better. So anyway, the central venous pressure should normally be about 0, but in this case, you want it 8 to 12. If it's less than 8, you give either crystalloid or colloid. Don't get me started on the difference. Crystalloid is fine. Colloid works just as well. It's much more expensive. It's much more difficult to administer. There's also industry pressures from the guys who manufacture crystalloid via, i.e. normal saline or lactated ringers, versus the guys who manufacture colloid. Technically, lactated ringers get you less of metabolic acidosis from the excessive amount of sodium chloride, especially chloride, and you don't get the hyperchloremic metabolic acidosis as much from the lactated ringers, and there's a little bit of potassium in there, blah, blah, blah. Give them crystalloid, all right? If you want a discussion on that, I'll give you an excellent chapter in a book called The ICU Book by, I think it's Paul Marino, and you can read all about that, and then, you know, go drink a beer. Sorry, there it is again. All right, the mean arterial pressure, this is excellent. You want it greater than or equal to 65 or less than 90, or rather, and less than 90. So you want it between 65 and 90. If it's less than 65 or it's over 90 and you've already given fluids, you don't squeeze an empty tank, but if you've already given fluids, vasoactive agents. That's where your levofed and your epinephrine come in, or your vasopressin or whatever else they're on. And remember, make sure you got to have orders for that. Keep their MAP above 65 via this pressor and this much fluid. If you think that the guy's blood pressure is a little soft, even if they're not on pressors, get some orders for some pressors before you leave, just in case you have to break that out. And you don't want to suddenly have to need that, you know, on the highway, because you can't start that de novo. We're not allowed to turn that on. So if you think there's going to be a problem, if you think that airway needs to be secured before the patient leaves because their mental status is questionable, if you think they're going to have pressors, start them before you leave. Get that airway secured, get those pressors online, make sure that you have adequate access and adequate ability to change an inherently labile, inherently unstable patient.
We can't start a pressor that we carry?
To my knowledge, there aren't any standing orders to start them from scratch. You have to have ranges for that. We can't start epinephrine de novo when they're hypotensive. You can get orders for it, but you can't just do, I'm pretty sure there aren't any standing orders for SCT to just
because we're not in an emergency situation.
Right, to just start epinephrine. There are emergency 911 orders for that.
Right.
We have epinephrine, we have levofed and epinephrine in the 911 ambulances, but you have to have orders for use the levo between this and this to keep the MAP goal above this when you're doing SCT runs. We can't just start blood or that kind of thing.
No,
but we can. I'd prefer you get medical direction for that before you start pressors in the field, because if we're starting pressors, then we missed something when we left, or they changed when they left.
okay.
We can't just start that. From an emergency medicine perspective, from a 911 perspective, yes, there actually are orders for levo now in the state protocols. I'm pretty sure I got them right here. But from a sepsis management, I'd prefer we not start the norepi or the levo or anything else because we can't start new hemodynamic active agents de novo in the back of the bus. Now, if we have medical direction for it, if we have orders pre-existing, or we call up the guy, that's why having that number right is so important, and go, hey, we're losing our pressure here. Can we start epi? What's your goal? What do you want to...
I'm glad you clarified that, because I would have felt comfortable starting a pressor that we have on a 911 without calling for orders. I would have been okay with doing that.
If push comes to shove and there's a communications breakdown or something, can you? Yeah, practically you can.
But it is a better idea to ask.
It's better to tell them, because what if they have a bad ejection? What if they have a bad ejection? Yeah, Joe and I were going back and forth about this a couple of years ago, because I was always incredulous when he told me that we couldn't do this. And I was like, what do you mean we can't start epi, or we can't start levo, or we can't give blood, or that kind of stuff? If you have standing orders for it from a 911 point of view, then you can do it. But you can't start, like from an emergency standpoint. I can count on my hand the number of times we have ever started pressors at SEMS. But usually we don't start like an epinephrine infusion de novo on the highway. There are times when you got a guy who's septic and you know it's coming, and you just get orders for it. And if, hey, if it happens, use that. And then yes, absolutely. Don't call them, don't bother, just turn it on. But if you get a guy who goes to hell and you didn't have him on pressors beforehand, and you're like, yeah, now I really think I need it, call them up. They'll probably tell you, go ahead. But most of the time, this is using a pretty big gun here. If we're going to use levo, or we're going to use epi, or we're going to use dobutamine, 1/3 of the time dobutamine causes hypotension, 1/3 of the time dobutamine does nothing, 1/3 of the time dobutamine causes hypertension. They may have another option first. Hey, why don't you give them 250 and then see what happens? Call me right back. Why don't you start him on dobutamine because he has an ejection fraction of 10%, and some of this is myocardial contractility, and that might work better than epi, or that might work better than norepinephrine. I'd prefer that we talk that one through
You wouldn't
first.
be carrying anyway.
Right, or unless they give it to you. There are guys who will
So if
transport
you're
on.
asking for a possible pressure, they may say, yes, I might use this is why.
Right.
And give you what you need to go with.
Right, and if
Okay.
they're really septic, that's the kind of stuff we should know ahead of time. But you never
Yeah.
know; they might change. They might be on the road and they might go south on you. Like, shit, now I need it.
Yeah.
So just anticipate that. I'd prefer you talk to them though, because sometimes there's, especially with these older, more complicated patients, there's stuff that we just don't know. And keep in mind, this is partly designed by ACEP for ICU docs,
Right.
and it assumes that we can just use anything, and that's a little tougher in the field. But it'd be better if you talked to him and said, hey, this is happening. And if he says, oh, you know what, he's got, advanced cardiomyopathy, dobutamine is better for him, and this is what I want to do, or epinephrine is better, or, this guy, I know him, I've worked with him for several days, he really likes his milrinone. I've had people do that, and they
You like our milrinone too.
I love milrinone. But anyway, that's
Friend and foe to me.
Yes.
Yes,
it is. But if you find yourself in a situation where you have a MAP less than 65 or greater than 90, and you have to start something from scratch that hasn't been started before, it'd be better to talk to BMO first, because they probably know this guy better.
That makes sense.
Anyway, the SCVO2, you want that greater than or equal to 70%. That is the central venous oxygen saturation. Oftentimes, we're not going to use this. Again, this is designed more for the ICU. This is the oxygen saturation in the venous portion of a central venous line. So that assumes that you're in the internal jugular, or you're in the femoral vein, or you're in the subclavian vein, and you are measuring the venous oxygenation. And basically what that says is, if it's less than 70%, you don't have enough. If that other stuff, if CVP is good and MAP is good, that basically says that you don't have enough blood to carry around the oxygen, and you need to start transfusing red blood cells until you get a hemoglobin greater than 10 or a hematocrit greater than 30%. Again, that's part of the difference, because I don't want us to de novo go, well, my SCVO2, which we don't monitor, is less than 70%. I'm going to de novo transfuse blood now. That's getting out of what we can do. If it's less than 70% and the blood isn't working, then you start taking up inotropic agents, i.e. not chronotropic, inotropic. So do I use dobutamine? Do I use epinephrine, et cetera? That's part of why I want us to talk to him about that. And again, if I'm weighing which of the 3 pressors I'm going to use and I don't just straight up know and I'm talking cardiology, you bet your ass that guy's going to the ICU. Speaking of blood, there will be times when we are transfusing people blood for bad traumas, for GI bleeds, and we're going to talk a little bit about blood, and then I promise I'll stop yapping because we're almost out of time. Risk-benefit ratio is often weighed. And again, I expect if we're going to be transfusing blood, there should be orders for that. Hang 1 unit, hang 2 units over this much time at this rate, pre-medications or not. Type and cross, and you got to weigh the possible complications, which we'll get to. State regs, care, storage, transport. Have you ever given blood before? Honest to God, I've never hung blood before. That's not something I do. I don't know how.
It's a nurse thing for you.
What's that?
It's a nurse thing in your department?
Yeah, I don't hang blood. I order blood when I need it, but I don't hang it. So there's a couple of different antigens that you got to be aware of, and you got to be triple sure that you're giving the right blood to the right patient for the right reason. Antigens A and B, and we'll talk about RH and HLA. If you have you have antigens. There's 3 rules for this. You have antigens to everything that isn't you. Nobody has antigens against O, and AB has antigens against nothing because they're A and B. You wouldn't want to have an antibody, rather, you have antibodies against whatever isn't you. Nobody would want to have an antibody against themselves. So a type A guy has type B antibodies. They'll kill type B. Type B guy has type A antibodies because they're not me. Type AB can't have an A or B antibody, or 1/2 of their blood antigens would destroy the other half. So they can get blood. They essentially have no antibodies, and they can get blood from anybody. Type O, everybody likes type O because it looks like nothing. But type O has antibodies against everything that isn't them, which is everything else, A and B. So they can only actually, type O people can give their blood to anyone, but they can only receive blood from other type O people. So normally the blood bank handles this and nursing handles this to make sure, but please, please take the extra 10 seconds and make damn sure that their blood type is this and I'm giving them this. So you can get transfusion reactions, which is basically hemolytic anemia if you give them the wrong ABO type. And also there's RH. This comes into contact a lot if you have pregnant patients. Now we don't have very many pregnant SCT runs, but you might have one day, you never know. Or you might have a normal patient who's getting blood where the ABO is matched, but the RH is not. Rhesus factor. Basically, if you're RH positive, you're not going to have any RH antibodies and everything's fine. But if you're RH negative, especially if you have gram-negative moms of gram-positive kids with vaginal bleeding, if you are an RH negative person who gets RH positive blood, on the second, your body will say, oh, look at that. That's not me. I don't recognize that RH antibody that's on that antigen that's on that blood. I'm going to make antibodies against it. And then by the time you get your second transfusion, or in this case, the second kid for a pregnant mom, you will have RH antibodies waiting in your RH negative patient. They get some RH positive blood, destroy it. And they get hemolytic reaction and red blood cells are popping all over the place. Their bilirubin goes through the ceiling, their oxygen carrying capacity goes to hell, and you have a sick patient gets sicker. You also have HLA, which is human leukocyte antigen, which is, believe it or not, it's a lot more. I give the blood bank a lot of credit because it's a lot more complicated than ABO and RH. There's like 32 different HLAs, human leukocyte antigens, which are multiple other antigens of varying degrees of importance that you get, especially problems with you have blood from multiple donor sources. And that can actually be a problem because it's like micro doses of antigen that isn't you. There's whole blood, which is everything. That's plasma and FFP and platelets and red blood cells. We give that occasionally. We can do that now under the new formulary. There's packed red blood cells, which we can do. That's basically red blood cells in about 250 milliliters. Your average Coke can is about 350 milliliters. There's FFP, which is fresh frozen plasma, which is plasma and clotting factors. This is good for people with coagulation deficiencies, people who are getting warfarin reversed where you don't have Kcentra to give them, thrombocytopenic, TTP or thrombocytopenic thrombotic thrombocytopenic purpura. And then if you don't know, I call it, if you don't know cryo, and it's frozen blood with, a lot of times it's got hemophilia A patients. It's got factor 8 in it, which they like, and it also has factor 9. So if you don't know if they're A or B, if you don't know cryo, that's where that phrase comes from. Von Willebrand's disease often will get cryoprecipitate because they are factor 8 and von Willebrand deficient. There's actually 3 different types of von Willebrand disease, but oftentimes they'll get cryo or they'll get FFP. Sometimes you'll get patients on albumin infusions, which I'm not mistaken, I think we could do. Am I wrong?
I think so.
Yeah, I would think we could do that. Albumin, it's not so much that it's a magic protein that you need, but oftentimes those really third-spaced, really swollen guys will, where solute goes, water follows. They will give them albumin to make sure that their blood vessels are full of solute, full of albumin protein, and that will keep the solute in their blood vessels. It will keep the fluid in their vessels for longer. Otherwise, within like an hour, if you get a bad SIRS patient who, you know, is starting to get urinary output failure, kidney failure, you're not making enough urine, the nurse calls you up in the ICU and says, hey, this guy's kidneys are going to hell. You know, his urinary output is less than 30 milliliters an hour. That's usually the trigger. 0.5 milliliters per kilogram per hour, but whatever. You'll give them albumin, which is basically fractionation of pooled plasma protein, and it allows you to retain fluid in the vessels longer. They also have plasma protein fraction, which I've actually never given. It's 83% albumin and 17% globulins. That's Final Jeopardy territory for me, but that's the same function. This is the holy grail. If you ever could come up with a synthetic blood, polyheme as one, it's still an area under research and development, and be able to transport oxygen around in something that looked like blood, but you didn't have to get it from people, and you could manufacture it, that'd be the holy grail. You wouldn't have to transfuse anybody ever again. And you could make it antigen-free, too.
You probably make
You make $1 bazillion. A bazillion. Bazinga.
Bazinga.
Start working on it.
Or give it to science.
Yes, that'd be awesome if we could pull that off. But that's not going to happen anytime soon. So, reasons for blood transfusion, this should be fairly obvious. Hypoglycemia. See, that's what happens. Hypovolemia from blood loss, anemia with symptoms, so people getting lightheaded, people with active heart disease and hemoglobin less than 10, like guys having chest pain who have hemoglobin 7, that's too much stress in their hearts, so the AHA actually recommends you transfuse those guys. Decreasing oxygen carrying capability, decreased clotting factors, that's when you break out the FFP, and that's kind of a function of sepsis. A lot of times they'll start just oozing from everywhere as they go into DIC, and you find those guys getting FFP, or they'll use FFP or Kcentra or both to reverse Coumadin on a bad head bleed that you'll then transfer to a place with neurosurgical capability. This is more of a skill set for those of you who can see the pictures, but basically it goes through the steps of confirming that you're supposed to give blood, right patient, right blood type, right blood product. Am I actually giving packed red blood cells? Am I giving platelets? Am I giving FFP? Am I giving whole blood?
Dr. Geller, we can transport blood that's been running for a reasonable amount of time with all the correct cross checks, but we can't hang another bag.
We can't start blood from scratch.
Right. No, but one's infusing and they want another unit going.
Yeah.
We can't do that.
To my knowledge, no. It doesn't allow us to start it. Now, if you got around that and say started 2 at the same time, you could theoretically
slow one down just a little bit.
Yeah, you could theoretically not break protocol because they were both going when you left. But I would not. It doesn't allow us to start it from scratch.
So that might be our Bergman Windman's run where we got a 4-hour ride in front of us for some reason.
Yeah. So if
Since
you
we're
could
doing what, 2 to 4 hours for 1 unit
per unit, yeah. Unless it's like we just bought these from the new trauma center. We just bought these whole these blood warmers and these like pressure infusers. It'll empty in like a whole unit in like 2 minutes. But
if they need another unit of blood when we get where we're going, they can do it at that point.
Right.
We turn it off, we leave the bag, we give them the bag so they know what we have.
Right. And just make sure to document if you don't finish all of it, like how much of it was finished or when you did finish, so that when we're looking at the call, we know that, okay, this blood went in and his vital signs did this. And that sort of goes into what we've been talking about in terms of documentation. Make sure you're It's not just an incredibly thorough initial assessment and then magic happened and you wound up at the other place. Make sure it tells a story of, as I was going, we did this, and his vital signs responded thusly, etc.
So hanging a second bag isn't a continued transfusion, it's a new transfusion. Every bag is a new transfusion,
Lovely.
right? So
Yeah.
that's what I guess.
Yeah, you really can't start a second one from scratch.
Yeah, it's not,
You might be able to
it's
get,
not a second one, it's a new one.
Right.
you might be able to get around it if you had two at once, but I've never seen people bend the rules like that.
Yeah.
I'd rather
Big
That's
enough
a long transport.
responsibility.
I'd rather not do that. So let's just keep it to one and how much you did, unless there's
We
some
can make New York
And
or
that's
behave at
clear
all.
in the protocols.
unless there's some extenuating weirdness, and if that happens, you need to call medical control. Maybe that person shouldn't be going
That
back
was Joel's
around.
call, the weird one.
For those of you who couldn't see Joel's face, it looked like this.
Yep, just like that.
Exactly. All right, so stuff that goes wrong with blood. Allergic reactions to the allergens in the blood. That's actually pretty common. We talked about the HLAs, the human leukocyte antigens. There we go. There you go. And so your body sees some degree of allergic thing in there, and it's like, ooh, I don't recognize that antigen. I'm going to go attack it. Oftentimes you get itching, hives. You basically stop the transfusion, give them Benadryl, turn it back on. Bacterial contamination.
On the subject of any histamines, do H2 blockers help with this at all?
Yes.
So Pepsi would be
Yeah,
something.
it's all the same immune reaction.
Okay.
Pepsid and Benadryl, and steroids probably not going to help you fast enough to make a difference. Just turn the transfusion off, give it to them. If they feel better, turn it back on. If not, you're stuck. Just turn it off entirely. Bacterial contamination. This is really tough for us to catch, but this is a possibility. Sometimes you get bacteria in the blood, and you basically just made them septic. You just made them bacteremic because you introduced it directly into their bloodstream, and now it's in their bloodstream, and now you're screwed. If that happens, stop the transfusion and watch for sepsis and start getting aggressive on that. But it's very tough. I mean, if they develop a fever and like sudden shivering and start getting septic right in front of you, I suppose that's a possibility that might have been what happened. But that's very tough to diagnose without literally culturing the blood, culturing the tip, culturing their blood out of their vein, etc. Febrile transfusion reactions. This is not quite the same as an allergic reaction where there's some allergen that you have an allergic reaction to, but occasionally you don't get like the whole flat out bacterial contamination, but there's a couple of little lipopolysaccharide fat sugar combinations, or you have recipient antibodies against a couple of leukocytes that are running around in the blood, and you attack that. It's not an allergic reaction. It's just is an immune system response to the blood, to specific things in the blood that your body considers potentially infectious. That's why a lot of times when you see people getting leuko-reduced red blood cells, packed red blood cells, it is because you have your recipient, your patient, has antibodies against the leukocytes in the donor blood. So you get leuko-reduced, not as much white blood cells for you to attack. Decreases your odds of a febrile transfusion reaction. It's the best way I can think of to explain it. Most of the time you're leuko-reduced, especially if you are a chemo patient and you're very immunosuppressed. You want as few foreign substances in there as possible. And a lot of times those are the guys who get these specially leuko-reduced transfusions to put as few foreign substances in there as they can, because they can't fight it off. So if that happens, if there's a fever, anti-fever, antipyretics, antihistamines, stop the transfusion, very similar to an allergic reaction. But a lot of times, I stand corrected there, leukocyte reduced is for immunosuppressed people. Hemolytic transfusion reactions, this is if you really screwed up and you give them the wrong type of blood. ABO or RH incompatibility or whatever, they just start lysing it en masse, and all the red blood cells explode like 1,000 bubble wraps all popped at once. Iron goes everywhere, bilirubin goes through the ceiling, patient might turn yellow, they get extremely sick very, very quickly. That can be either immediate with you or it can be delayed in a couple of days. And that's really bad when that happens. There's also a thing called TRALI, which is transfusion-related acute lung injury. And that's basically ARDS from a transfusion. This is very rare, but it's very similar to the febrile transfusion reaction, immunoglobulin A incompatibility, or really RH incompatibility. It's kind of like another RH type of factor. That's bad. There's no way in God's green earth we could see that coming. But that's a thing that can happen. Also, they tend to bleed. A lot of times the packed red blood cells don't have much in the way of clotting factors in them. And so you can just kind of ooze everywhere. Bad CHF patients, that's why we give it so slowly, because 250 milliliters can be a lot to them, and they can get fluid overload. No joke, from a unit of blood. A lot of times we'll get CHF guys who also have GI bleeds, and they'll get a unit of blood, 40 Lasix, a unit of blood. You can get hypocalcemia, problems with excessive potassium, get very cold. Anybody here ever been sick or injured or whatever, you wind up in the ED for some reason, and somebody gives you a bag of room temperature saline?
Feel every drop of it.
Oh yeah. Oh yeah, you shiver with hypothermia. You can get hypothermic from this too. That's why blood warmers are good. Airborne, this doesn't really apply to what we do on the ground very much, but understand that both on the ground and in the air, these patients are likely to be labile. They are likely to hide multiple potential multi-organ failure that will decompensate at any time in any direction, have a high index of suspicion that they are going to crater at any time, and try and stay out far ahead of them as you can. Also, at altitude, for anybody who does wind up in the air, at unpressurized vehicles like rotor wing, everybody gets hypoxic and every air pocket expands. Pneumothoraxes get bigger. It's actually a big problem. And so their oxygen demand goes up, their SaO2 drops. Just expect that to happen. Incidentally, for those of you who are interested in just random trivia, you don't get hypoxic and confused from cerebral ischemia in an airplane at altitude because the airplane's pressurized to about the level of Denver.
8 to 10,000 feet?
Yeah, 8 to 10,000 feet worth. So you don't, you feel like it's different, but it's not affecting you. Okay. If you blow a hole in an airplane, there's a depressurization event, something like that happens. And don't worry, stay calm. The oxygen mask will drop from the ceiling and you won't have to chill out. Everything's fine when the roof flies off. If that happens, statistically speaking, if you're at about 30,000, 40,000 feet, you have about 10 seconds to descend to 10,000 feet before you get so ischemic that you pass out and the plane goes in the ground anyway. That's about how long you've got until that depressurization happens. This is one of those interesting facts I picked up a while back. I thought was amazing. And maintain care with whether you're going on a ground unit or an air unit, that your ventilator settings and the results you're getting match. Sometimes 350 milliliters or 550 milliliters of tidal volume on our vent isn't the same as 550 milliliters of tidal volume on their vent. You go to your mom's house for Thanksgiving and 350 degrees is different on your mom's oven. So make sure that your equipment is able to maintain the patient in the homeostasis that they were in before you leave, even if you have to tweak some of the settings a little bit. That being said,
I tell you that all the time, John.
that being said, that's enough of me gabbing for one night. Y'all have a great day. Come and talk to me anytime in the ED. Come visit our new trauma center. I'll give you a tour.
It is beautiful. Thank you, Dr. Gallo.
Thank you.
Thanks, guys. Oh, yeah.
Dr. Gallo, I don't think you officially met.
We did. We
saw you
met
just the other
Oh,
day.
yesterday.
Good to see you guys.
I
Thanks
missed
for
the
this.
whole thing.
I was gonna be here at 6, but we ended up going down to New York City, so.
Sorry, Chris. It's all
That's
good.
what happens down here.
That's what happened.
I told you.
Yeah. No, I know.
Alrighty. No.